So my name is Faraz. I'm a PGY2 for those of you who haven't met me. My topic is contrast-induced nephropathy. Does it exist? And then I just want to thank Dr. Sinner, Dr. Kim, Dr. Kendall, Dr. Chu, Dr. Turner, Dr. Warshaw, and Dr. Turbini for their help with this presentation. So just going over the definition of what is contrast-induced nephropathy, it's basically just an AKI following the administration of contrast. So the definition of the AKI is an increase in serum creatinine from 0.3 above their baseline in 48 hours, or an increase in 1.5 times their baseline in 7 days. And in order for it to be contrast-induced nephropathy, you should have contrast administered and then see this rise 24 to 48 hours after the administration of contrast dye. So where did the idea of contrast-induced nephropathy come from? So in the 1950s, they used a very high osmolar contrast dye called diodone when compared to our lower osmolar contrasts that we use today. Given the high osmolarity of this contrast dye, it could have actually been potentially nephrotoxic. The other thing is they saw during that time that some patients after receiving contrast dye became anuric and developed renal failure. So they started performing some observational studies, but they didn't have adequate control groups at that time. And as we know, observational studies can only establish association, but not causation. So we did have a lack of evidence. One is that randomized control trials are typically the best to compare or to actually evaluate whether this exists. However, randomized control trials for this disease entity would be unethical. Likely because you can't really randomize someone into a study that they don't need. You can't give someone a CT with contrast if they don't need it. The other thing is if we do believe that contrast can be harmful, we can't randomize people to get something that's harmful. The other reason we don't have good evidence for this is that there are a lot of confounding variables. People who tend to get CTs with contrast versus those without contrast tend to be sicker patients, patients that are potentially septic, patients that are potentially in shock. These patients also tend to get more NSAIDs, more antibiotics, which are nephrotoxic, which can lead to an increase in their serum creatinine from baseline. So we do have new evidence in recent years. There's been many new studies, particularly retrospective studies and meta-analyses that are claiming that contrast-induced nephropathy doesn't exist. So these studies are using control groups to compare. So the first study, McDonalds et al., this study was done in 2016. It was to determine if there was an association between contrast exposure and the incidence of AKI. What they did was a retrospective study, basically comparing contrast CTs to non-con CTs in a hospital center from 2000 to 2010, and they looked at the incidence of AKI. So they divided the groups into low risk serum creatinine less than 1.5, medium risk creatinine from 1.5 to 2, and high risk creatinine above 2, and they looked at over 150,000 scans. They also used something called propensity matching, which is essentially just to get rid of, or try to get rid of confounding variables by comparing people who got contrast CTs to non-contrast CTs with similar baseline characteristics. So the results from the study was actually between the low risk, medium risk, and high risk groups. There's no difference in the incidence of AKIs. And the conclusion from the study was that IV contrast may not be a causative agent in AKI. So another study by Hinson et al., also in 2016, wanted to compare contrast CT with non-con to determine if it is independently associated with AKI, like the previous study. So this was a retrospective analysis, basically comparing contrast CT to non-con CT to patients who didn't get CT at all. And they looked at patients in the ED from 2009 to 2014, which included around 18,000 visits. They used logistic regression modeling as well as odds ratio, and they also propensity matched. Their results between the three groups was that AKI rates were similar, and there was no statistical difference between the groups. They also noticed that there was no increase in CKD, no increase in dialysis, or all-cause mortality between the groups. So their conclusion was, being the largest well-controlled study comparing AKI after contrast, there is no association with the increased frequency of AKI after IV contrast administration. Next, we have a couple meta-analyses. The first was by Aycock et al., which examined studies comparing rates of AKI, the need for RRT, and mortality in patients who did and didn't receive contrast. This study included 28 studies, around 100,000 patients. However, most of these studies were observational, and they didn't find any difference between non-con and contrast CTs in AKI, renal replacement therapy, or mortality. What they did see, though, because of the observational studies, was that patients with higher lower GFRs, higher creatinines, tended not to get as many IV contrast studies compared to those with normal GFRs. So the next study actually does compare patients with lower GFRs. This meta-analysis was done by Yan-Qian Li, and it was basically to evaluate the incidence of contrast-induced nephropathy in patients with CKD. So what they did was they compared patients who got IV contrast with those who didn't, based on their CKD level. So they compared CKD1 with CKD1, CKD2 with CKD2, etc. And they found between the different CKD levels, there was also no difference between incidence of AKI in non-con versus contrast CTs. So despite all of that, why does this myth perpetuate? So one thing is that our serum creatinine isn't a static number. It's constantly fluctuating depending on our hydration status and other factors. So one theory is that we tend to ignore decreases in creatinine. So if we have a patient who has a baseline creatinine of 0.9, and then we get a repeat serum creatinine and it's 0.6, we kind of ignore it, chalking both to be normal and don't really take that into consideration. However, if that same patient, instead of going down by 0.3, went up by 0.3, we'd consider that possibly an AKI. And if they got contrast, then we would chalk that off to contrast-induced nephropathy. There's actually been studies that show that before and after CT, patients on average have equal amounts of increase and decrease in their serum creatinine. Another argument is that patients who are admitted tend to have, on average, higher creatinine. This could be due to long boarding times, they're dehydrated, they haven't been eating well in the ED, they're sicker patients. But again, the patients who got contrast, because their creatinine is also elevated, they are also labeled as contrast-induced nephropathy. So just other things to consider, that just because it has a name doesn't mean we should take it as seriously. So for example, contrast-induced nephropathy, we have this name for it. However, given the previous studies that I showed, it doesn't look like it's that nephrotoxic, especially since there's not difference between non-con and contrast CTs. However, we give a lot of weight to it, and we delay our CTs waiting for the creatinine. We don't really have an alternative to contrast CTs. I mean, we can always get non-con, but it might not necessarily show what we need to see. On the other hand, vancomycin, it doesn't have a name like vancomycin-induced nephropathy, but we do know that it is a nephrotoxic agent, and it has been shown to lead to AKIs. Also for vancomycin, we have alternatives like linezolid, but we don't see the delay with administration of vancomycin. Normally, we just go ahead and give the vancomycin without checking their creatinine. So those are just things to consider. Now, all the studies that I have gone over were for specifically for IV contrast. So now all contrast is the same. There actually have been studies that show that you do see renal injury after intra-arterial procedures. This could be due to the increase in contrast load, but there's also a lot of confounding variables with this. Patients who get these procedures like cardiac catheterizations tend to be a lot sicker. They could have heart failure, cardiogenic shock, leading to decreased perfusion to the kidneys. They can have procedural complications like dislodgement of plaques, which could lead to renal embolizations. Or they could have like an intra-aortic balloon pump, which again leads to hypoperfusion of the kidneys, causing damage. So despite all the evidence shown, the statement of the ACR currently is that at the current time, it is a position of the ACR Committee on Drugs and Contrast Media that contrast-induced nephropathy is a real, albeit rare entity. So in conclusion, everything's kind of about risks and benefits. This is a diagram from EMCrit website, which basically is saying don't really consider the GFR when you're deciding whether or not a patient needs contrast. It's more about whether or not you think the patient needs contrast for the study you want to see. And then that should be the sole reasoning behind what study you choose. In reality, though, medicine is a little bit delayed with the evidence. So a lot of hospitals still require you to get contrast, still require you to get the creatinine and the GFR before determining which study you need. And then having this discussion with the patient about the risks and benefits. Yeah. So that is my talk. Any questions? Sure.
There are two questions around the same concept. Do any of the studies include transplant recipients and just in general?
No, they would never do it. They would never do it. It's just too expensive to get the organ. Yeah. The transplant surgeons really don't like contrast. They are a big believer in contrast therapy. There's no studies to do that. But the transplant surgeons, because this was so difficult to get, they were worried about any cost.
The question was if any of the studies included transplant recipients, and the answer was no.
No, you probably shouldn't. So this general idea of who gets contrast and who doesn't, that you worry about the end. So in a contrast study that's potentially Mike syndrome, that the patient's going to die in front of you will have a very bad outcome if you don't give it contrast. So it's STEM. We don't care about that because if we don't fix the coronary artery block, dissecting aortic aneurysm or leaking abdominal aortic aneurysm or trauma, right? These patients require contrast studies. It doesn't matter the creatinine because not doing the contrast is a bigger risk than a small, even if you believe contrast is PE studies, probably not so much because you could treat them and do another study, a BP study or other study later on, and you could heparinize them. If you're really worried about a PE and the creatinine is 3 or 4, no one knows really what the risk of contrast-induced nephropathy is. And why in the hospitals probably not to give contrast. We don't in stroke patients. We don't wait for the creatinine. We don't wait for the creatinine in trauma patients. We just send them off, and everyone does one. Good question.
Oh yeah, I actually gave contrast once to a transplant patient who got a dissection, and we got yelled at by the transplant surgeon. But it's hard. It's a decision to make, and we involved the surgeon, and ultimately they were upset about it. But
I think if there is an indication for a transplant patient to get contrast, I would call the transplant doctors first and get them involved in the study early.
Yeah.
I think the threshold to get contrast for a dissection should be pretty high with anybody. But in a renal transplant patient, maybe even a little higher.
You know,
But
if
if you
there's a
think
better
it's
test,
life-saving, good.
if there's a better test, then you should do it, or less dangerous, because if it's thoracic, you can get a TTE, abdominal, you can get a sonogram, so
Right.
there are other options. Sorry, TEE, there are other options, so maybe you shouldn't get it.
Yeah. In fact, the TDE would be better for better dissection study anyway.
I realize it's harder to get it, because less people do it, but it doesn't mean you should give up.
But if you get the contract, if you get the transplant people on the side to get the echo patients, the echo study quicker, I think that would help. So I wouldn't, in the transplant patients, I wouldn't give contract. You know, for abdominal studies or appendicitis, or you don't really have to do that. You know, the contrast doesn't save their lives. It makes it easier to read, but it doesn't save their lives.
Standard of care for appendix is not on anyway, so
Yeah.
anything over 7 millimeters is impossible.
Yeah, so I would say if the GFR is less than 40 cc's per minute, that's usually about 45, 40, somewhere around that. Then I think the hospital would prefer to not do it, and the radiologist would prefer to not do it. I don't really care, but then I think we should find another study.